session for the next hour or so. And I'd like to kick off the Q&A session by saying a big thank you to Caitlin Dobson, Emily Loftus and Chris Anderson, who have helped to organise this 2-day event. This morning I've seen them running around between the two buildings, putting up poster boards, handing out cups of coffee, giving out people's tags, all sorts of things. But in amongst all of these things, the other thing that they've been doing over the last few weeks is to collate questions from you lovely people. So on my faithful clipboard here, I have a number of questions that you've already sent in, and I'm going to be posing these questions to the panel members throughout the next hour. But I would also like to invite you to ask whatever questions come to mind. So you might have questions about the future of neuroscience and how robots are going to be involved. You might have questions about mental health. You might have questions about how come Ed has such beautiful illustrations on his slides. And you might also have some questions remaining from the talks that we saw earlier. So if you can keep those questions in mind, then I'm going to come back to them over the course of the next hour. And please wait until a microphone has come to you, otherwise you won't be able to hear your question properly. Before we get into the questions, maybe it would be nice if we have a little bit of a round of introductions. So I'll just introduce myself briefly and tell you a little bit about what I do so that you have a bit of context, and then I'll let everybody introduce themselves in turn. So, as I said, my name is Jennifer Cook, and I'm a Senior Research Fellow here in the School of Psychology. And I think it's fair to say that I probably have kind of one foot in the CHBH and one foot in the IMH, because my research is kind of partly clinical, partly neuroscience, and partly psychological. So everyone in my research team, in some way, asks a question that is related to autism or Parkinson's disease. And what we see in these conditions is that it's very often the case that social challenges and body movement challenges overlap. So we often see in patients with autism, for example, people commonly think that these individuals have primarily social challenges. But when we talk to patients with autism, we find that they often say the things that really bother them on a day-to-day basis are things like trying to ride a bike, or their handwriting, or trying to throw a ball. And I think Parkinson's disease is kind of the opposite of that. We think that patients with Parkinson's disease have primarily motor difficulties, but actually some of the research that's been conducted here at the University Hospital, led by Hugh Rickards, has shown that many patients with Parkinson's disease have social difficulties as well. And so the research that my group tries to do is to unpack why we see both these social and these motor difficulties in these clinical populations. Maybe you can say a little bit about your work.
I'll try. My name is Andrew Bagshaw. I'm co-director of the CHBH, so thank you all for coming. My work is mostly associated with using brain imaging techniques in relation to sleep and epilepsy. And recently that's led me towards the IMH, mainly because both sleep and epilepsy have generally mental health interactions or relationships with mental health, and I think trying to understand a little bit more about why they are risk factors, what's actually going on, how we can develop brain imaging techniques to tell us a little bit more about what's going on there. I think that's where, to me, some of the interactions we can have with the IMH and the kind of ideas we've heard today are interesting.
Okay, thank you. So I'm Matthew Broome, I'm Director of the Institute for Mental Health, and like Ed, I'm a psychiatrist. I still work 1 day a week in the NHS. My, research background is mainly in early psychosis. Like a lot of colleagues in Birmingham, we're part of improving treatment for the young people with early psychosis, but more recently I've become more involved in mood dysregulation and mood instability, relationship between autism and schizophrenia, an interest of Jen's as well, and also the philosophy and ethics of mental health care.
Thank you. So I'm Louise Arseneault, and I am working at King's College London, the Institute of Psychiatry, Psychology and Neuroscience, and I also work with the Research Council, the ESRC, the Economic and Social Research Council. I am their Mental Health Leadership Fellow, so I champion mental health research, and I try to push social science in understanding mental health problem more. So I am especially interested in social factors that can contribute to the development of mental health problems, so I did lots of research on bullying, but I also study loneliness, and I try to understand as well the protective factor of social support.
So I'm Ole Jensen, I'm co-director of the CHBH, and what we focus on in my group is measuring brain oscillations in human subjects. And our particular focus is trying to understand how the brain operates as a network by investigating how these different regions are communicating in terms of brain oscillations. And we also applying that knowledge to try to understand different kind of disorders again with the background that these disorders might be explained by something going wrong at the network level. So we have had a particular focus on ADHD, and we are trying to investigate how oscillations in brain oscillations might be different in ADHD patients, and how, for instance, Ritalin, a drug used to treat ADHD, is affecting these brain oscillations.
So I'm Ed Bullmore, and I'm a psychiatrist. I have spent most of my time doing research, first in neuroimaging, and then, as I've just been talking about, more recently, drug development, and that's led into neuroimmunology. So I've always thought that neuroscience is going to ultimately change practice, but I think that's not necessarily going to happen all that fast, and it's still a key focus for me to do that. Just to answer your question about the pictures on my slides, I got those pictures done because I published a book called Inflamed Mind, which tries to sort of communicate some of these things, and I really didn't like them. Actually, no, I wanted proper textbook pictures with, a spleen that looked like a spleen, and, little lymphocytes and stuff. And my editor said, don't do that. Well, she said, you've got to strip it down, really, to communicate about the immune system, the brain, all this stuff. You've got to make it much, much more accessible, and that's what we ended up with. So it wasn't my brilliant idea to have those figures. I was dragged kicking and screaming in that direction in the interest of engaging with a wider audience.
Has to be done.
Okay, so maybe we can kick off the Q&A session with any remaining questions for Ed that lead on from his talk. Yes, please.
I was very intrigued with this immune regulation and depression. I was thinking, in case of bipolar disorder patients, when they have a manic episode and followed by a depressive episode, is there any difference on their immune response during the manic phase and the depressive phase?
Yeah, well, that's a good question, which I have been asked several times before, and I don't think there's a very good answer to it, because the best answer would be a longitudinal data set, I think. So you followed a bipolar patient or cohort of patients as they went through the ups and downs of their mood disorder, and you had simultaneous immune markers measured, and as far as I know, nobody's collected those data. If you look at the cross-sectional studies that have been done for bipolar disorder, of which there are many fewer than for major depressive disorder, there is evidence, I think, for increased inflammatory proteins, but that's not really getting to your question. I think to answer your question properly, you need to track a cohort with very good, frequent, psychological phenotyping and very good simultaneous immunophenotyping.
Thanks, Jen. So thank you for a really interesting talk. I was struck by the final slide where you said sort of maybe, but not yet. And I wonder if one approach might be within a targeted sort of sample, such as maybe people with postnatal depression, and obviously has evolutionary perspectives as well. And I wonder if that might be an interesting way to look at pre and post-inflammatory sort of biomarkers.
Yeah, I think yes. I think a lot of people are interested in postnatal depression because, of course, the fetus is a great big antigen from an immunological point of view, and it's interesting to think about what might be the immunological challenge of birth, pregnancy and birth from the mother's point of view. when I said it's not going to happen soon, I mean, what I really mean is new drug development is just going to take forever. And actually going after postpartum depression, I don't think is going to make it faster. Because that, from a commercial point of view, from a sort of drug development point of view, a lot of companies are going to look at that as a great big risk. But I don't think that there's necessarily nothing we can do in the meantime. I mean, I think we could, I think we could probably get a better grip on, simply coexistent physical and mental health disorders than we currently do, just by rearranging existing services. I mean, if we, for example, made it our business to collect better mental health data on people in medical outpatients and better biomedical data on people in psychiatric patients, if we built data platforms which allowed us to integrate over, large patient populations with very good, when I say very good, I mean, immediately deliverable, immediately accessible standards of psychological and biological phenotyping. I think we'd immediately learn something quite interesting, and we might be able to organise services around, those patients who have some coincidence of both of those symptoms. I think that we could do that right now. I mean, I don't know if you're planning to do that here in Birmingham, but in Cambridge, one of the things that we're excited about is that the government's put 100 million into the concept of a new hospital for children and young people, which is a partnership between the Acute Medical Trust and the Mental Health Services Trust. And that is going to bring under one roof at least inpatient mental health and physical health services together. And I think that just that co-location, that breaking down of the traditional, segregation, might stimulate all sorts of marginal improvements that could be of tremendous benefit to patients without necessarily having to wait, for the Jensens or Roches or other big companies of this world to produce, a brand new drug and biomarker combination, because that will take time.
I think Andy had a question for you as well.
I do. Which could be more broad for the rest of the panel as well, but it's so coming from the point that the hypersomnia, insomnia category is there in about 90% of patients, I think, with a diagnosis of major depressive disorder, and sleep itself is associated with inflammation and immune system function generally. I just wondered where you see sleep's fitting within your model, and whether it's, and to some extent it's broader within mental health generally.
Yeah.
Where does it sit? Is it important? I mean, there is some evidence for sleep problems preceding depression in particular, but...
Yeah, I mean, I personally don't have any... I mean, I think I'd be interested in what other people have to say about the role of sleep in mental health disorders. I don't have any particularly deep insights into how, the immune system, depressive symptoms, and particularly sleep, might be related to each other. And I certainly, again, going back to the point about lack of longitudinal data, and your point that sleep disturbance sometimes precedes mood disorder. If you wanted to kind of link all of that into bodily changes in the immune system, you need those longitudinal data, which we just really don't have. There might be better glimpses of understanding from the animal literature, but I must confess I'm not immediately familiar with them. I mean, I think it's very interesting to think about sleep. I mean, certainly what we know clinically is that inflammation tends to be associated with what's sometimes called atypical depression. This is Brenda Penix has this theory that it's the patients particularly that overeat, oversleep, tend to gain weight and have some obesity, some inflammation, some metabolic disturbance, that atypical cluster. She has argued is where the inflammation is most likely to reside, and that would imply that hypersomnia rather than insomnia was a symptom of inflammation. But I'm sort of going some way beyond what I think is actually in the, what you can actually certainly say. I think you could certainly say that hypersomnia, hyperphagia, that sort of atypical clinical phenotype phenotype is more associated with inflammation, but how exactly all of these things are interrelated causally, I think, remains to be seen. I don't know if anybody else wants to go on to see.
Yeah. Can I just add, maybe not necessarily on inflammation, but on the social aspect? So we did research on loneliness and sleep problems, and we could see that, and we look at loneliness among young adults, so 18-year-old people, instead of most of the research on loneliness, which is done on older kind of groups. And what we found was that you could have it, we did find an association between those who were feeling lonely and having sleep problems, and it was mostly associated with the quality of sleep. It was not associated with the length of sleep, you know, sleeping less or sleeping more, or the latency. It was really about the quality, and that association kind of remained even controlling for depression. We also looked for an association between loneliness and inflammation, and we couldn't find something yet, and we think that maybe the assay was not kind of sensitive enough to find something. But it was interesting that from a social point of view, to see that those who feel lonely had sleep problem, and we think that maybe it's because of this sense of threats. So when you're sleeping, you know, you're at the most vulnerable, basically, and we take from the animal literature, the animal kind of sleep in groups, usually. So if you feel lonely, and in this case it was not you're sleeping alone or not, but if you feel lonely, I think that you feel that you're more vulnerable, you know, to kind of threats, and that could affect your sleep pattern. And that even though you were not depressed.
Good. Can I broaden this question out a bit? Because I think sleep is just one of many different lifestyle factors which may integrate with biological factors and impact on mental health. And this brings me to my first question on the delegates list, which I think is an important question to sort of zoom out and start with, because this question emphasises something that we haven't explicitly put out there today, but we are having a joint launch event for the CHBH and the IMH. And, you know, you could have had 2 separate launch parties, you could have had double the amount of wine receptions, but you've decided to have these launch events on the same day. And presumably that represents the idea that you think there's something important about integrating neuroscience and mental health. There's some important marriage between the two. And the question from the delegate is, why is integrating mental health and neuroscience important, and what are the challenges?
Right, yeah, that's a very, very important question. So where to start? So I guess crudely speaking, I guess the first element is that a lot of our mental life is linked to the behaviour of the nervous system, as Ed pointed out. We know where that's physically located. So on one level, that's the one element of truth. There's an element of certain biological facts that help us think about mental health. But as we've heard today, very well described, what we want to do in the Institute for Mental Health is not only be drawing on neuroscientific advances, but also wider scientific advances, whether that's immunology, social science, etc., etc. So I think it's not a monogamous relationship in the sense mental health draws on expertise from all scientific endeavours. I think it's a particularly close and valuable relationship from neuroscience. As broadly conceived, and I know the work Ed will generally about things like extended cognitive cognition, social network theory, all these things about thinking about a brain as more than just an isolated nervous system. So I think that's the key thing, the challenges of it. I guess the one that I kind of face, and I guess Ed alluded to, is that, you know, I was a medical student during the decade of the brain. I'm aware of the funding that's happened, and yet I'm also a psychiatrist. So that issue that Ed raised when he started to talk about sitting out patients is that the advances of neuroscience have not yet yielded any clinical benefits for our patients. So I think for me, it's trying to keep seeing the future. Where can we go? Give that optimism and excitement. I think that's what we hope to showcase today, really, from our speakers, is where that's going to go in the future and help us. And what I hope we'll try and instantiate with the CHBH and IMH, we have a sort of neat and powerful translational pathway from basic neuroscience to patient and service delivery and policy change. But other colleagues are wrestling with the same problems. I'm very happy for us to respond.
I'm interested, we're not in a monogamous relationship.
Sorry.
So the rest of the day is
That's
cancelled.
Ola as well, you see.
We will be having separate ones from now on. I just want to take, coming from the other end of it, from the imaging side of things, I think one of the things that always strikes me when talking to people about their expectations of brain imaging is they kind of expect that it tells you something about their particular brain, and that we have the ability to extract information about an individual's brain using current brain imaging techniques, which I think is largely not the case. And I think it's if you look at the use of imaging techniques clinically, obviously in neurology, if you expect to see an obvious abnormality, then fine, they're very important, and that's why there's so many MRI scanners being sold. If you look into psychiatry, it's not really particularly useful to have MRI or any other technique because you can't extract the right information. But presumably, maybe not, but presumably there is information that you can extract out of brain imaging techniques that would actually be clinically useful. And if we're going to be able to do that, not only do we need to develop the methods, but we need to understand how the brain works generally when there isn't something not quite right about it, but then we also need the experience and the expertise coming from psychiatry and coming from neurology, because neurological disorders are often associated with psychiatric disorders as well. So there is a general disruption there. We need those expertise to understand exactly what's going on, and I think that's the only way we're going to do that is if we work together, and then hopefully, imaging would be useful.
I think,
I mean, the next question on my list, and I feel like I have to say it in an angry voice, is brain imaging doesn't have anything useful to say about mental health, because mental health is too complicated and dependent on psychosocial factors. And I wonder if, Ola, can you give some examples? Or can you comment?
Yeah, no, I mean, so it is a good point, right? So if you look at the DSM, there's nothing about brain imaging there in helping diagnosis, and it is an issue for the brain imaging community, but that does not mean we should not keep on trying. And I think it's also about bringing different research cultures together. So bring together people who are doing brain imaging and people from psychiatry, and that is exactly why we also chose to have the launch event together, right? And the question is, how do we sort of create the fertile ground in the future for having more collaborations such that brain imaging eventually will be useful in psychiatry. And some of the initiatives we're trying to take is, for instance, to start PhD programs. So we mandate there should be, say, a more clinical oriented supervisor and a more imaging oriented supervisor, and then have a joint project. So if the current generation of researchers have not been able to make the link, the hope is that the next generation of researchers would be able to do that. And this is why it's so important that we have these centers working together.
So to come back to your question's point of view, I mean, that question to me embodies the sort of the dualism that is still sort of in medicine and in psychiatry. This sort of tribal warfare between the people that think it's psychosocial or brainless and the people that think it's all biological, biomedical or mindless. And it gets quite nasty sometimes with people throwing inflammatory words across the barricades. And I think really we should try and move on from that, because one thing that neuroimaging has told us already is that social events, socioeconomic adversity, trauma in childhood is associated with changes in brain structure and function. So the idea that there's a sort of social realm which doesn't impact on the biological realm is, to me that's a Cartesian hangover that we ought to snap out of. And we ought to recognise that actually, social events leave biological imprints very often. And that to me is the fascination of psychiatry in relation to neuroscience, because psychiatry, we know a lot about psychosocial risks, and figuring out how those relate to the genetics, to brain organisation, to what we're learning biologically. That to me is where the future could become very exciting. The other thing I'd say about imaging in relation to, mental health now is it's not, just remember what happens if you see a patient in a psychiatric clinic and you refer them for an MRI scan. Okay, at least in Cambridge, they trot off to the MRI scanner, they get in the scanner, they have the scan done, and then, no disrespect to professional colleagues, but a radiologist will, basically take the film, hold it up to the light, squint at it, and think, is there a tumour? Is there a lesion? Can I see anything qualitatively abnormal in that scan? No. And you get back a single sentence report, normal for age. That is what usually happens. And it's not the failure of imaging, it's the failure to apply the quantitative skills, the quantitative methods of analysis that are routine in imaging research have not got across into radiological NHS diagnostic practice. There's really no reason why we couldn't make much better use of imaging data than we currently do. We don't need fancier scanners. We do need bigger databases. We do need, sort of computational algorithms, AI type approaches to pattern recognition in single scans. We need to do better than just the radiological eyeball. But I think that's where a lot of the failed promise, I think, is attributable to. It's not the technology, and it's not the fact that there's nothing sort of potentially identifiable in an individual's patient scan that might be of diagnostic relevance. We're just not applying all the quantitative firepower that we have at our disposal when it comes to analysing scans in NHS practice.
But why is that? Is it a reluctance or is it finance?
Well, I think it needs some pretty serious infrastructural. So you need to have a world in which images are collected in a very standardised way. You need to be able to get them, and this sounds utterly trivial, but I think it's quite often mistaken. You need to have ways of getting patient identifiable imaging data out of an NHS computing domain and into a high performance computing domain, which might not be under control of the NHS. You need to have high throughput, well validated pre-processing pipelines that can crunch the data, and then you need to be able to do all the sort of clever artificial intelligence type work so that you can locate your index scan in the context of reference databases. And then quantitatively say something about either the probability of a poor or good outcome, or diagnostically. I think I can see this happening first for Alzheimer's disease and neurodegenerative disease, but I get the feeling that community is perhaps a little bit further down this road. But I don't see why it couldn't happen for other mental health disorders. And to me, there's no atom splitting required. There's no great hard problem to be solved. It's really organisational and making sure that what we know from the research side is actually deliverable on the clinical side.
And sorry, I will open it up in a minute, but I'm in charge. So,
do you think that that means that the NHS will have to outsource that work to AI companies to make it efficient?
Well, I think a lot of big tech companies think that medicine is, antiquated and ripe for disruption. And I think we might not yet be seeing this in this country very clearly. But I mean, I think a lot of tech companies, Google, for example, I know Microsoft, are interested in what you might call digital radiology, applying artificial intelligence to get better quality diagnostic information from existing scans. I think it's going to happen. I mean, the question is how fast. And I think one of the things those companies are looking for, not that I can speak for them all at all, expertly, but I think one of the things they are concerned about is finding partners, and we would hope to be such a partner, and maybe Birmingham would hope to be such a partner. They want to find partners which are capable of collecting the data in good order and holding the data securely, so that they can basically parachute in their algorithms and train their algorithms and assess the performance of their algorithms without pulling the data out of the NHS and into the Google or the Microsoft database. I think it's probably the best. My version of the future is not going to be the tech companies or the NHS. It will likely be, at least in this country, partnerships between them.
Okay.
We might come back to some of those themes later on, but I should let some other people ask some questions. Kim, please.
I have a question, I guess, primarily for Ed, but maybe it will serve to bring these areas of neuroscience and mental health together to some extent. So my area of interest is in attention and short-term memory. And a PhD student came to me and said he wanted to look at the effect of air pollution on working memory. And he just started into the literature, and the first 10 or 15 studies that he turned over all implicated inflammation as the intervening variable between air pollution and working memory problems. So I guess, in a sense, my question is, if that working memory is something that is tractable in a scanner, MRI or MEG for that matter. But I'm just curious from a psychiatric perspective, are people thinking about issues, sort of the basic cognitive issues like working memory and attention, the effects of inflammation on those functions? Because it's clear that if your working memory, short-term memory isn't working, I mean, that's a very severe problem, likely to lead to depression as well as a whole host of other issues.
Yeah, I mean, I think there is a bit of work on that. And I mean, other people might be familiar with this in more detail than I am. I mean, but I think it hasn't yet been explored as rigorously as you might hope. I mean, most of the sort of experimental medicine studies that I'm aware of, where so your PhD, a nice way for your PhD student or somebody to look at this might be to say, well, okay, let's take somebody with good working memory performance, let's make them inflamed, and then let's see what happens to their cognitive performance, and let's see what happens to the brain systems associated with those cognitive functions. And that's tractable. There are ways of ethically inducing inflammation. It does have that effect. Well, so I think that's beginning to get things onto the right track. If you come at it from the clinical side, I mean, of course, depression is certainly associated with cognitive impairment, and actually, all of those patients that have inflammatory disease and psychological symptoms, they very commonly talk about this thing called brain fog, which is some kind of mild cognitive impairment. It's probably a working memory deficit or a planning deficit, amazingly under-researched. I mean, patients talk about it all the time. If you look in the medical literature for good quality studies of cognitive impairment in the context of inflammatory disease, what are people talking about when they say brain fog? There's not much there. Again, I would say that's the shadow of dualism. The rheumatologists, the people that see these patients, for whatever reason, they don't think it's part of the syndrome, brain fog. They don't want to investigate it. But, yeah, why not cognitive function? It's not going to be just emotional functions. I don't think the brain's going to be particularly selective in how it responds to these inflammatory signals. I think it's an area where we need more work, of course.
Ole.
Yeah, so just a short remark. So Ali Mazahiri just published a study in which he showed that inflammation induced by a virus resulted in a modulation in a change in how alpha oscillations were modulated. Just wanted to say that. No, I mean, so the point being that there are some of these types of brain activities that we think are very important for how the brain is processing and organizing information processing that are directly linked to information in this case.
More questions from the audience? you have any questions from Twitter?
I haven't had a chance to look yet. Yeah, I will.
Okay. Oh, okay. So I have a question that was emailed in from a member of the Royal College of Psychiatrists. And the question is, what can Royal College of Psychiatrists do to help raise the profile of the new IMH-CHBH regionally across the Midlands as well as nationally?
Might be Ed and me.
So I think, and Gareth's sitting here. So Gareth is from the Royal College of Psychiatrists, and he's leading this project to bring neuroscience into the psychiatric training curriculum, which has been a huge success. And I think what you've done, or what you're doing here, which is putting mental health cheek by jowl with neuroscience and embedded in the NHS, I think is a superb environment to develop that kind of agenda. So I would say, maybe the Royal College of Psychiatrists should be thinking about Birmingham as a sort of incubator, one of a regional centre, which can be used to promote this sort of neuroscience and mental health agenda more broadly.
And just to add to that, Gareth's invited us to an event next month, isn't it? October, we're having for the West Midlands trainees around the neuroscience curriculum and improved training. I guess the angle I would like to see is also for our consultant colleagues as well, because I've sat in, I'm sure as Ed has, in ward rounds where colleagues have talked about mental health problems as being very fixed, static, degenerative, and the excitement and the knowledge we have now of neuroscience being dynamic and plastic. Sometimes we need to reinvigorate that and have a bit more optimism with our clinical colleagues. So I'd like, I guess, if a request to Gareth is to see what we're doing with trainees, also to think about CPD for our consultant and peer colleagues, perhaps.
Sorry.
No, I was just going to say, it could come from the other side as well. What could we do for the Royal College of Psychiatrists in order to facilitate that?
Yeah.
There are things we can do to help have that dialogue, and I think it is a lot of the time about dialogue with consultants, with trainees. There's people out there who want to understand about the cutting edge of imaging in relation to psychiatry, and we just need to be open to that.
Yeah, well, that's the other question on the list as well, actually. So practically speaking, what are the things that we're going to do to promote collaboration between the basic research scientists and clinicians? I have had this experience myself, that I've been to the hospital and I've sat in on rounds and things like that, and we've had some fantastic ideas about research projects that we'll do together, and then they've kind of fizzled out because you sort of need a PhD student to drive it forward, or a little project grant or something like that. So what are the sorts of things that we're going to be doing at the CHBH and IMH to promote that?
One thing I think we're doing a little bit is to have research networks on particular clinical themes. So we have an epilepsy one, we have a sleep one, there is a stroke one. I think partly the idea there is to just get people mixing and knowing who each other are on a regular basis. So 2 or 3 meetings a year, you will meet up with the clinicians who are in that speciality in this region, and then you can have a good dialogue from them. When a research opportunity comes up, then you know who they are and you can facilitate it in that way. You still need to then get the money for it, but at least when the opportunity arises, you at least have the basis for something to work from.
Yeah. Can I just follow on with this? I think from being an outsider, I think that you need more to kind of create situation where people kind of get together. I think that people know about the work, and they kind of interact with each other quite often. But I think that there needs to be some kind of more changes embedded in the workforce, to make sure that there's kind of greater interactions between clinical work and research. I think that the funders need to be involved in that kind of discussion, making sure that clinical people have better chances to kind of do research, and researchers have greater experience, in the clinical field as well. And I think it needs a little bit more than just kind of getting together, discussing, because then when we go back to our lives, we drop that, because, we get back into, the routine, and it's just really, really busy. So I think that there needs to be kind of a greater kind of changes, and maybe the centers will be able to kind of do that or provide that. So
do you mean that like the MRC or the Wellcome Trust, they need to start funding centres that are collaborations from the outset. Is that the sort of thing you're thinking?
It could be, or I think that there could be as well kind of individual kind of schemes to kind of support better kind of clinical people to do research, kind of having clinical fellowships, you know, to really kind of support clinicians in being able to conduct research and spend a fair bit of their time kind of doing that. I think that we're losing quite a bit of young people, early career researchers as well, kind of moving outside, you know, the country to kind of develop their career and grab those opportunities that are offered internationally, but not necessarily in the UK.
Yeah.
So I think that the funders have really they have to do a better job in kind of trying to find out how can we retain those young people and how can we provide, you know, kind of dual experience clinical research, you know, in the training, in the workforce.
So I agree with all of that, and I do think the reforms, the MRC training curriculum are very important. I think the Wellcome Trust and MRC, that's all terrific. But I also think that we should try and democratise research in mental health a bit more. And I think the idea that research is the province of an elite group, mostly medical. Some small percentage of the actual total mental health workforce, I think is not particularly helpful. And I think, if you think about, certainly, in Cambridgeshire, my impression is that if you go around to, community mental health teams and you talk to people, who might be doctors, but they might be nurses, they might be social workers, they might be, any kind of practitioner. A lot of people do have questions that you could regard as research questions, like, why is the outcome from this intervention in our team apparently so much better or worse than the same intervention delivered in a different team? Is it because we're dealing with a different patient group, or are we applying the intervention differently? Is there some other factor? I think those questions are very, very quick to surface in many people's minds, and I don't think we're doing a very good job of allowing people to satisfy their curiosity and get started on research in a sort of and a less intimidating way than saying, okay, you've had an idea, the next thing you need to do is write a Wellcome Trust Fellowship proposal. And so then you say, well, to people, well, what's blocking you, what's stopping you? And one obvious thing is time. I think most mental health practitioners are flat out busy dealing with impossible clinical loads, and there's very little time to think and prepare research ideas. And I think the other thing that we could do a much better job of is acquainting people with looking at clinical data in the aggregate, which wouldn't necessarily be scanning data, but it could be trust-wide data, it could be regional data, so that people can begin to think about their practice or their team in a wider on the basis of a wider sort of evidence base.
Yeah.
Again, I don't think that's impossible to do. It just needs that I think is a challenge in terms of how we handle clinical data, how we visualise clinical data, and making sure that we're feeding back aggregate clinical data to mental health practitioners in a way which allows them to begin to kind of grapple with the questions that I think a lot of people have.
Sort of mentioned a few practical things, but we are trying to, as Ed said, really to democratise the research base, so trying to get our youth advisory group to be very active in research and develop their skills in that. And also we're very fortunate that both mental health trusts we work with do support the non-medical colleagues developing a research career. And we're very, very good to hear that I think the lead of the clinical research network has left, but he was here earlier, and the fact that now people can be invested in a PI independent of their clinical background and independent of the methodology. So as Ed said, in the old days the model was you had to be doing an RCT, whereas now you could have somebody develop in social science, in health economics, in neuroimaging, for example. So that's really crucial. And I guess the other thing, keep my marriage analogy, a lot of what I do is doing those relationships, trying to bring researchers and the clinicians together. It's a struggle for time, but I think the willingness is there, and we have to make sure we recognise it fully. The practical data, you mentioned it briefly at Cambridge, working with Children's Hospital. We're fortunate in that both mental health trusts, which includes Birmingham Women's and Children's, are very analogous to the Cambridge setup, want to use the clinical data for research purposes and have electronic databases for that. So we could potentially do some of those kind of work there. We've already begun publishing on some of the early intervention psychosis data, predicting long-term outcome using the kind of tools that Ed mentioned. I think there's a great wealth and excitement. I remember Simon Lovestone saying in Oxford, the data from clinical services about dementia outcomes dwarf massively the data from RCTs. Yeah. So having the NHS is a great resource for science and for clinical improvement. And the trick is how we harness it, really. And it's really administrative, bureaucratic, political hurdles rather than scientific.
I was thinking about the data because recently we have almost all the hospitals have electronic databases. So there are lots of data sitting around. And one of the hurdle is this confidentiality and ethical approval. I heard somewhere, I think in UK, there is some experimentation doing the synthetic data where you would have all the essential clinical data anonymized. And that allowed the researchers to do modeling or play with and try to identify if there are any correlations. So for example, in Birmingham, we have multi-ethnic groups. So when I prescribe clozapine, not all patients develop diabetes or weight gain. There are certain patients, but other patients are not. So it's ideally only a very small handful of patients. If we have a huge data set where these are anonymized, I can look into more details, and that can help me to formulate an appropriate research question. So in that regard, I wonder whether IMH would consider to develop some kind of a synthetic database, including both the medical and the GP practices data, as well as the hospital, that we can actually follow this patient from when they come into my clinic, go to the GP surgery, and longitudinally, how did their metabolic syndromes develop, or how did their immune response or any other chronic disease interact with their relapse.
Sounds great.
I mean, it's an aspiration, Alice. I think it's what we want to do. I know my colleagues are working in the primary care database. We had a talk from Jay Desmunchie of the IOP talking us about linking healthcare data with social care data, for example. And I know that's something some of the political leaders in the West Midlands are very keen to do. So we also have expertise, so we're part of the Alan Turing Institute and HDR UK in Birmingham, but it's a question of line as well. We are getting there slowly with, I mean, Stephen's working with the primary care data and some of the trust data now, but we haven't got the systemic overview as yet. It's more project specific, I suppose, is what I'd say at the moment. But yeah.
I agree completely with with what you said. I think if we could link up all of these.
I think if we could link up primary care, acute medical services, psychiatric services, social services in an ethically okay way, with no breach of, confidentiality, I think that would be a superb basis on which to develop new ideas about treatment improvements. And I think it will come. I think there are several organisations that are kind of pushing at that, and I know that, for example, the MRC has a plan to launch a mental health sort of data platform, which would seek to integrate those kind of records, not just within a particular region, but across the country. So I think it'll come, but I agree with you completely. If we could get that sort of integration across different domains of data, we would have an extraordinarily rich database to think about.
Thanks. I'm Andre from Mental Health. This isn't a question from Twitter, but it's an observation. I tweeted about 20 minutes ago when Ed said, actually I'm paraphrasing Ed, so excuse me, we need to move on from the biological versus psychosocial bun fight. That got lots of engagement on Twitter. And I think lots of people agree with that.
Right.
How
do we do that?
I think that we need to promote interdisciplinary research. I think that still today, and I work at the Social, Genetic and Developmental Psychiatry Center. So for 20 years, we tried to kind of get together and to kind of develop projects, that would integrate all these kind of different elements or background. And it's just really, really difficult. I mean, even when you come down to language, it is as basic as that. there are some of my colleagues, they will talk about genomics or omics or whatever, which is very difficult to understand for me, and sometimes I think that when I talk about social relationship, the importance of that, they will look at me kind of going, and I think that, what I do is very complicated, because how do you measure kind of social relationships, It's not as easy as doing, kind of getting information from a DNA or a test tube or whatever. I think that there are issues as well about trends, what is fashionable. It's funny to say, but I think that in research you do have fashion, At some point it's going to be neuroscience, another time it's going to be genetics, So there are some fashion, and I think that we really need to get together and put mental health at the center. Quite often I think that people will promote social factors, disciplines are fighting for what is their value. I think mental health is at the center of what we do, and we have to get together around that and bringing our knowledge and expertise around that, instead of saying it's all genetics or it's all social factors. So I think that, and I'm not sure whether kind of cancer research have the same problems, but I think that definitely mental health, we do kind of struggle, and we seem to pull, away instead of getting together. But I think that interdisciplinary, and again I will bring this back to the funders, which I think should encourage that. More interdisciplinary research. I think that that's the way that we're going to, provide better answers for mental health.
Can I respond
Yeah,
briefly?
yeah.
No, thank you, Andrew. It's a hard one, and I think the disparity is something you aspire to. It does require kind of risks and time to do well, I think, and working together, and that's what we're trying to do in Birmingham, by the way, we set up the institute. But it is a challenge for funding, publication, career progression, all the other things. That's the one area. I think, echoing Louise, I always say, well, we haven't got very far in the last 20 or 30 years. We can't say no to a certain body of knowledge, whether that's service user knowledge, carer knowledge, particular discipline. We have to take on all resources we can and use that maximally, really. And I'm quite influenced by the work of Ken Kendall, who's a geneticist, but also writes about philosophy of science in relation to mental health. And he will say, we lost in a monocausal model of mental illness we were trapped in the 1950s. To move beyond that, and I think a lot of what Ken talks about the complex etiological models, I find quite attractive and important. So it's really a generational element. As Ole said, we need to think about people stepping outside their silos and thinking about the problem we're trying to solve. Where we're getting short for time.
Oh, yes, please.
Thanks very much. I'm sort of grappling with a discussion that took place on the radio between an eminent professor here in the University of Birmingham who runs a Character and Virtue Institute, and also with a colleague of yours, Louise Plowman, who's written a recent book called A Blueprint, How DNA Makes Us Who We Are, which is sort of broken quite a lot of myths, or trying to challenge teachers and educationalists in terms of how we can change or not change the environment, because basically what we're born with, we can't change. The environment is so unstable that children will not change. And he's done several cohort studies of identical twins and non-identical twins in different environments, and basically the twins in different environments have very similar characteristics. So my question is this is rather depressing in a way, that if in your research in bullying, if schools can't have much effect on children's behaviour because they may change within the school, but when they leave the school they go back to being a bully again. And I'm just worried about I'm quite concerned about what Robert Plonin is saying, that character and education doesn't matter a damn, that these kids are just going to leave and do what's in their DNA. So I just thought that might be quite interesting to pull out.
It's not just, you're not asking that just to me, is it?
No, I'm not just asking.
Because I have to go back to the office tomorrow. Probably bump into Robert. Well, I think in some ways that, hang on, how to answer this question. I think that Robert does a great job into demystifying kind of the role of the genes, when it comes to development. And I think that genes is really important, and I think that we need to address their influence when we kind of do our research. At the same time, I would say that that to me, I think that the social aspect and experiences are still important over and above. And while kind of Robert tends to kind of show how similar are monozygotic twins, I would kind of probably show you pictures of monozygotic twins that are terribly different as well. So I don't think that, you know, that we should make conclusions based on how similar or how dissimilar they are. But I think that experiences and social relationship also shape people quite importantly. So I think that this is probably kind of my experience, you know, kind of at the SGDP, that you have someone who kind of really value the role of the genes at the expense of other factors. I'm much more kind of inclusive in saying, you know, they work together, they're really important, but of course I'm much more into the social aspect of things. And don't forget that it's not because something is heritable that it cannot be changed.
So I haven't read Robert Plomin's book, but I'd be surprised if he was really as reductionist as you're implying. And maybe he is? Okay. Oh, he is. In that case, I would say I disagree with such a reductionist view. I mean, you know, I think if you look at the heritable data on depression, for example, it's about 30–40%, something like that. You know, there's a big chunk of the variants that genetics hasn't got a grip on at all. And if you look at the individual genes that have been discovered so far, I mean, each of them is an absolutely minute effect size, right? I mean, you know, there's 140 of them, I think, or something like that at the moment. But each of them imparts, you know, I think in the order of a percentage point of risk. So it's clearly not, you know, sort of Mendelian genetics. It's not a situation where, you know, you've got, you know, a lesioned chromosome and that causes a lesioned brain, which causes a mental health disorder. It's just not as simple as that. What I personally think is particularly interesting, although it does add yet another layer of complexity to all of this, is the epigenetics. So, you know, what we're seeing, and again, this is clearest in animal studies at the moment, is that if you stress an animal, you cause an enduring epigenetic change, in which means that for any given sequence, any given DNA sequence that you've inherited, the transcription of that gene into proteins and therefore the functional implications of that gene are modifiable by experience. You know, so you can make animals, you can traumatize animals, you can show that has a change in behavior, and that can be related to epigenetic modification. And I think that sort of gene-environment interaction with epigenetic marks potentially conferring long-term changes in, you know, the downstream genomics, not the sort of DNA sequence. I think that is probably going to be quite relevant to common mental health disorders. And again, it's another way of thinking that cuts across the psychosocial biomedical divide, because it says you can have a psychosocial risk, like a trauma, that leaves a very, you know, specific molecular imprint on the biology.
So I think that's going to, we're going to have to finish there, and we have to bring this to a close. I'd just like to finish by reflecting on the day a little bit and saying that I really appreciate that we've had 2 talks where we've really been able to have clear examples of why we need to think about social factors and biological factors, why we need to bring together neuroscience and psychology when we think about mental health conditions. And that was so clear in the talks, and so uplifting for the opening of our new centres, which aim to do just that. And I've also been really uplifted by some of the discussion, especially the discussion we've had about how there really are these initiatives in place for bringing together some of the patient data and the neuroimaging data so that we can really use that data to apply our algorithms and find out more about mental health conditions. So I personally have found this to be a really uplifting day. So thank you very much to all of our speakers and panel members. And I'll just pass over to Matthew, who wants to say a few closing words.
Thank you, Jen. Just want to finish for our first day closes, just to thank everybody who's been part of organising it today, so Ola, Andy, Deb, Caitlin, Emily, Naya, Chris, our youth advisory group, and also Andre for helping us with our dissemination for the event. So you've all done a fantastic job, as Jen said earlier. Thank you very much, Jen, for chairing us and for our great keynote speakers today. So a couple of more administrative things. Please remember to bring your lanyards, who's coming tomorrow, and your kit and everything. And we'd like to invite you to a drinks reception afterwards. And thank you very much for your attention today.
Thank you.